Okay, so we are back, and the first PTCA was done on September 16, 1977, and the people who did them were Andreas Grunzig, who's obviously, as you many of know, as the father of interventional cardiology, as well as Dr. Adolf Bachmann. And this is the picture of their setup. You can see a wine glass, and you can see varieties of different things, including the balloon catheters. This was a very informal environment the first time around, and this is an actual picture of the first balloon angioplasty. Here we go, September 16th, 1977, proximal LED. Um, and what is really impressive was 10 years down the road, it doesn't look bad. Balloon angioplasty works. But there are obviously varieties of reasons why we have reached today to our sophistication of coronary stent design, and that's because of two problems. One was the abrupt closure problem, where it happened after balloon angioplasty in about 4 to 8% of our patients. And as you can imagine, 1/5 required emergency bypass surgery. But the second problem was obviously restenosis, which happened in 30 to 50% of those patients. And out of them, 20 to 30% actually had to have revascularization. So as you can imagine, that after a balloon angioplasty, you have an improved lumen. However, there's an elastic recoil, which leads to early luminal loss, and then eventually there is a late luminal loss because of neointimal proliferation. So to treat and prevent acute closure, bare metal stents were developed. These were the first two, Cook GR2 and J.J. Palmer-Saz. And then 1993 was the BMS era. Restenosis improved. There was down to 20 to 30%. And there are a couple of trials, Benny Stent and Stress, which confirmed that stenting was better than balloon angioplasty. And by 1999, almost 80% of all the interventions required or had a stent insertion done. So as you can imagine, the idea behind this is you have this narrowed or stenosed artery, you put in a stent, and there is hardly any elastic recoil, but remain the persistent problem of neointimal proliferation, or what we would describe as restenosis. So while bare metal stents improved restenosis compared to balloon angioplasty, a new disease entity was created. It's called in-stent restenosis. So devices used to treat in-stent restenosis were brachytherapy, which is still available. Our institution does that, rotational atherectomy, cutting balloons, but we needed to create something to suppress the inflammatory response and to keep the lumen open. Remember, this was not as much of cholesterol driven as much as scar tissue driven. And that's when we wanted to create this idea that, yes, you have stenotic lesion, you put in a stent, and there is minimal elastic recoil, but also you want to prevent this further stenotic response, new intimal formation. So that led to the drug-eluting stents. The first generations, on top, I have the Taxus formulation, which is paclitaxel as a drug. There's a polymer coating on it, and the underlying stent was a Liberté stent. The Cypher was the another stent which was designed. It has sirolimus as a drug, and again it has a polymer of POBA BMA blend, and the underlying stent was a BX velocity. And as you draw a timeline from the 1977, from the very first day balloon angioplasty was performed, to the 2000s, you can actually see that everything got better. The failure where there was immediate occlusion almost went away. Emergency bypass surgery definitely went away. The stenosis rates dropped dramatically from 40% to less than 20%. Stent thrombosis reduced, as well as VLST. And as time has progressed, we continue to keep on getting better. The first generation drug-eluting stents, when you compare them, TLR rates between paclitaxel versus bare metal stent, or sirolimus, which is Cypher versus bare metal stent, in all categories, in every trial, it outperformed bare metal stents. And hence, it became very exciting for us that there was a clear need for moving towards drug-eluting stent, and that became the novel technology. However, there are some challenges with this first generation drug-eluting stent, namely late catch-ups. So Cypher and Texas, both of them, we actually saw that there were major adverse cardiac events rates at 5 years, amounting to 2 to 4% every year after that. So that was a little disappointing. And you can see that there was late stent thrombosis as well as very late stent thrombosis with this first generation drug-eluting stents, to the extent that it was slightly high with drug elution, and hence a concern sometimes about possibly moving back towards bare metal stent, which happened around 2000, 2008. But fortunately, we were able to develop the next level of technology, the second or almost the third generation stent as we speak. So Texas and Cypher also had some variations. We felt that with Texas there was higher late stent thrombosis, which led to death and MI. And with bare metal stent, there was higher restenosis, which led to excess death and MI. So then there was a need for this smarter design. So how did we end up creating the second generation drug-eluting stent? So we would take a metal design, a stent design, and then you had to have a polymer and you had to have a drug coating on that. So there are certain ideas. If you're a biomedical engineer, you want to think about all these features of a drug-eluting stent to make it optimal for the patients and their therapy. So first of all, you got to have access to lesions. So it has to be deliverable. So it can access and across lesion, flexible, visible. It has to be very good at deployment. There should be accurate placement, scaffolding, conformability through tortuous vessels, as well as good apposition, and most importantly, radial strength. Not only that, this has to be supported by clinical outcome data, whether it's patency, low strength thrombosis, or long-term mechanical integrity, as we know, which causes future restenosis and strength thrombosis. But then there are trade-offs. If you want to create a stronger scaffold, then you lose out on some of the flexibility. If you want something with higher radial strength, then it may not be as conformable. If you want to have a large expansion range, but then the profile sizes go a little bit larger, so deliverability becomes a bit harder. If you are asking for more radiopacity, then you almost have to say, well, maybe that requires more metallic footprint and a thicker strut, maybe. So the original stents were made out of stainless steel alloys, because stainless steel was corrosion resistant, very biocompatible, and relatively high radiopacity. So it was really used a lot. But then we quickly realized the value of platinum, chromium that was moved. But I think the current stents are all made out of cobalt alloys, because they are as thin as struts as you can possibly make without compromising on the radial strength. And they still maintain a good radiopacity, and obviously they are all biocompatible. So cobalt chromium or cobalt nickel have become the current standard for metallic drug-eluting stents. The stents are designed in varieties of formats, but there are two general principles. One is the continuous wire, and second is the multiple wire segments. As you can see, this is kind of a continuous wire formation. Then they're attached with links, or you can have multiple wire segments, which are again attached with links. So there are pluses and minuses of both. On the continuous sinusoidal technology, basically you take a single continuous piece of wire and it is formed into the sinusoidal shape. It is then wrapped around a mandrel to give the cylindrical shape of the stent. And eventually the stent is then fused in a strategic location to ensure maximum flexibility and conformability without the risk of unraveling. Solid tube can also be cut by laser and polished to make a scaffolding structure. So those are called laser cut stents. Unlike the one which we wove around a mandrel, this is a steel tubing which is cut by laser into certain shapes. So there are certain basic concepts of stent design. The rings, as we call them, they can be in phase or out of phase. This is an example where the rings are in phase. They are literally parallel to each other. And here the rings are out of phase. They are basically opposite of each other. We can design a stent and make their crests higher or shorter, which would allow for expansion. Obviously, you can also make the cell size larger or smaller based upon that. The bar arm length, which is also responsible for the crest size, also will allow you to decide on how much you can expand on the stents. But probably one of the most important factor are the links, the connecting links. And there are varieties of ways you can create connecting links. The straight or the simple ones are used less and less, but an S-shaped or a Z-shaped or a V-shaped, U-shaped are varieties of links which are put on in between the cell struts. As I described, the in phase and out of phase. So if something is in phase and it is very repetitive, it will give you better scaffolding. But if you're out of phase, it actually will give you more conformability so you can deliver the stent a bit better. So those are some of the trade-offs you have to decide when you're designing a stent. And as I described, if you have fewer crest versus more crest, you can expand it in much larger if you have more crest. Also, if your bar arms are longer, again, you can clearly expand it much larger. Connecting link, as we discussed, the fewer the links, the more the flexible the stents are with less scaffolding, the more the links, they're less flexible. But again, the more the links makes the integrity of the stent a little bit better. And closed cell design, where every peak is connected, is also available, but it's probably rarely used because it is a little too rigid now. What is recoil? The recoil is the amount by which the diameter of a stent changes from the expanded stent diameter with the delivery system balloon inflated to the final stent diameter measure after balloon deflation. And that is the recoil or the immediate recoil, early recoil of the stent. What is radial strength? In radial strength, a stent that is minimally compliant will better accommodate vessel diameter change due to pressure loading after the cardiac cycle. And hence, it's very important to have a stent with good radial strength. So once you apply the load, which basically means expand it with the balloon, and you remove the load, you basically try to understand how much of the stent itself is exerting outwards force, which determines its radial strength. And radial strength allows for very minimal recoil within the stent design. The anti-restenosis drugs have been studied in varieties of molecules. The taxes used paclitaxel as a derivative, but ever since then, I think we have pretty much moved on to Alzheimer's drugs, whether you go back to Cipher, but now more lately with the Resolute, which uses a taralumis, and then Promus and Synergy and Enzymes and so on and so forth. They all use everolimus. And this drug works through different phases of cardiac cycle. For example, all the Alzheimer's group of drugs are anti-inflammatory drugs, and they inhibit the mTOR, resulting in cell cycle arrest. Paclitaxel, on the other hand, inhibits smooth muscle cell proliferation through the stabilization of microtubules and thereby preventing cell division. You can also not only decide on which drug you want to put in, but you can also decide how long it will elute for, depending on its concentration. So, for example, the original stent using zotaralumis was one called Endeavor, where most of the drug was already dissipated within the first 7 days. But then the Resolute, which is the newer generation zotaralumis drug-eluting stent, the drug elutes for almost 6 months. Similarly, with Xience, the drug elutes up to 4 months, and the Texas, the drug eluted up to 30 days. Polymer is a very interesting part of the stent design because there's been a lot of debate about it, whether it's good or bad. But again, some of the basic fundamental ideas are that it protects the drug, obviously. The drug is attached to the polymer. It ensures consistent drug dose on the stent. It controls the amount and timing of release. Obviously, it gives the issues with them are sometimes mechanical integrity because polymer at the end of the day is a little plastic on the stent and it can crack. And obviously, you want to make sure that they're vascular, that there's compatibility and it does not lead to chronic inflammation. So all said and done, the two commonest polymer available today on the onyx bilinks and fluorocopolymer on the Zyte stents. So this is a quick representation of the first versus the second generation stent, and start from the left side, and if you look through, you can basically get a sense about how designs have progressed. So for example, you can clearly see from stainless steel we have moved on towards cobalt based alloys. Strut thickness has definitely reduced from 140 microns to 80 microns. Polymer thickness has also been halved. Drug has been moved towards more and more Olimus group of drugs. And we have also realized that the elution time frame is best between 3 to 4 months. So we kind of are now aiming for 90 days to 120 days for most of the drug elution technologies. That being said and done, we continue to have certain challenges. So for example, with RESOLUTE All Comers, there was no differences between the RESOLUTE and the Zymes, but you can still see that there is some uprise in the event rates as time goes by. Stent thrombosis, again, was no different, but there is a little bit of higher stent thrombosis over the next 4 years. So is VLST. So we have come a long way with drug-eluting stents. We went from Cypher in Texas, which came out in 2003, 2003 for Cypher and 2005 for Texas in US. And around 2006 and 8, we had this time where we were not sure about stent thrombosis, and hence there was actually a dip in DES, first generation DES usage, and bare metal stents kind of made a little slight comeback. But then we quickly realized by 2010 that the next generation, second generation stents such as Zymes, Resolute, Sporus, and then Synergy and all Onyx have far superior to bare metal stents. So this slide kind of shows where the challenge lies. Whether you take the Zymes Sphere or the Texas, you basically can see that there is about almost 2% event rates, 1.8% event rates per year after the first 2 or 3 years, and that leads to a TLF of 5 or 6%. It almost becomes 12 to 17% by the end of 5 years, and that's where we have to compete against other modalities of revascularization such as bypass surgery. Freedom trial may be one of the reasons why we did not do so well with drug-eluting stent is because of this crossover. After 2 years, there was a clear benefit of reduction of events in CABG group versus PCI with DES continued to have event rates, most of them driven by targeted lesion revascularization. And there's obviously this concern about metallic drug-eluting stents. I mean, this is a permanent implant in those coronaries, so those are over years they can become thrombosed because of some uncovered stent struts. What does it impair the cyclic pulsatility and the vasomotion? Can it lead to chronic inflammation due to late foreign body reactions and or hypersensitivity? There can be positive remodeling where the vessel keeps on expanding, but then there is late strut malapposition due to that. Strut fractures are observed. New atherosclerosis could be a nidus for it. And then obviously this question, the debate about polymer, whether it's good or bad, and how do we have to always give it? Can it be absorbable, and so on and so forth? Because polymer is there after the drug is diluted, whether you give it for 60 days, 90 days, or 120 days. The polymer is there for forever, and those can be damaged. They can swell, they can web, they can crack. There also been electron microscopy of evolutions of polymer. Because polymer on the DS adds to the problem potentially. Especially it can lead to poor integrity with thick coating of durable polymer. So you can have uncovered struts, hypersensitivity, excessive polymer, malapposition, late stent thrombosis, new atherosclerosis. This all potentially can be assigned to the presence of polymer. So we are going beyond the original idea of abrupt closure. We beat that, and we kind of have beaten restenosis, but we are in the era of optimal healing. We want that vessel to heal, the one we have treated with a stent. So a mature neo-intimal layer is probably the most important layer of the vessel for optimal healing. You want a continuous functional endothelial layer because endothelial cells are are there to communicate to the vessel media. It stabilizes the vessel wall. It prevents further neointimal formation, and obviously provides a barrier for thrombosis. So because of that, we are led to next generation of drug-eluting stents. And this kind of divides into three categories: the bioabsorbable polymer stents, polymer-free stents, and then bioabsorbable scaffolds. So Synergy is the one which has been in the U.S. market for several years, and it has a bioabsorbable polymer. The polymer is gone after the drug is eluted, which is basically after 3 months. It is only applied to the abluminal side, so it is not where the blood is flowing, but it is more towards the vessel wall, which I think is a smart design. And that leads to suppression of neointimal growth at the arterial wall and promotion of healing inside the lumen. So as you can see on the left side, you've got a photo cartoon of Synergy stent, which is 78 micron thick with an abluminal layer of a bioabsorbable polymer. And the Promise Premier, which is our current metallic DES, you actually have a 97 micron thickness with a all-around polymer. You can easily make a case what's the need for polymer on the endoluminal side of the artery. So as I just explained, you have the drug elution, which actually finishes at about 3 months with Synergy Stent Design, and the polymer is completely absorbed at about 4 months. So that polymer is also gone. Obviously, drug is already eluted, and you can clearly see that the tissue levels of everolimus drug is nicely maintained up to 3 and possibly 4 months. So this is the fundamental idea. You have this uncoated surface on the luminal side to promote cell coverage and adhesion. There is freedom from long-term polymer exposure once coating is absorbed. And then obviously there is targeted drug delivery reduces the risk of restenosis and inflammation on the outside side. This has been supported by several papers of imaging. This is a slide showing OCD results anywhere from 30 days up to 6 months, and you can see a very good coverage. I think as an idea, we have learned for optimal healing of a vessel, you require at least 70% coverage to prevent less-stent thrombosis. So one can make an argument that if you have an abluminal polymer, which is only on the outside side, this allows for a very proper endothelial cell function as well as coverage. Unlike that, the conformal, you actually have a lot of breakage on the endoluminal side because the endothelial cells cannot grow uniformly. This is an interesting slide which actually shows the amount of inflammation. As you can see, in terms of inflammation early on, rather the acute inflammation, with bare metal stents, it is very high. With Synergy, it is low. So, but in the pink bars, and so is with Resolute, Integrity, or Science Prime. When you look at chronic inflammation, on the other hand, you continue to have that higher with bare metal stents. Then let's go to the next category of new stent development, which is polymer-free stents. In polymer-free stents, you basically have drug coated onto the stent without any polymer. And this example here is of BioFreedom. It uses a drug called BA9, which is much more lipophilic and then sirolimus, almost 10 times. So the abluminal side of the stent, it is microstructured surface holes. It is basically sandpaper, so to speak, and that leads to vessel transfer of the drug and possibly also can shorten that. There's this novel idea where there are holes made into the stent strut, and the drug elutes actually from that hole on the abluminal side over time, what we call drug-filled stent. Cobra PZF is a very interesting novel technology. It uses a thin strut cobalt chromium coronary stent, but then it is coated with Teflon-like material called polyzine F, and that potentially, without any drug elution, leads to improved rates of restenosis down the road. And then the bioabsorbable scaffolds, I think right now that science is on hold for a few reasons, but I think it's a very interesting idea because you have to get tired eventually of all these stents which we keep on placing in those coronaries. So the Absorb design has a PLLA backbone. It's semicrystalline. It is circumferential sinusoidal rings connected by linear links. The strut thickness is a little bit big. It is 150 microns, and there are platinum markers in each ring. The drug is everolimus. It is coated with PDLLA 1:1 matrix coating. It is about 7 microns in thickness. It is conformal all around, and there is controlled drug release similar to Zions cobalt chromium everolimus stent. This is a photograph of Absorb versus Zions. Obviously, it clearly stands out how thick the Absorb biovascular scaffold is compared to Zions. But I think those things, those attributes of the stent strut in the first generation iteration was very important to maintain a radial strength. And as you can see, that there is no compromise on the radial strength on Absorb versus the Zions platform. So how does a bioabsorbable stent? I mean, this slide is specific to the BVS Absorb, but you potentially can use this in all bioabsorbable stents. And the first phase is the revascularization phase, where there's drug elution in Absorb. It elutes up to 3 months with everolimus. And then the second phase is restoration, where you have gradual loss of mechanical support, and there's restoration of the vessel. And then eventually there is mass loss, and there's complete resorption of the bioabsorbable material, PLLA. That happens in about 2 years. And this is done via nothing but hydrolysis. So water in the surrounding vascular cells and blood penetrates into the polymer matrix. The long polymer chains become shorter and shorter. Initially, hydrolysis preferentially cleaves amorphous T chains, leading to a decrease in molecular weight without altering radial strength. When enough tight chains are broken, the device begins losing its radial strength. And the good thing about stent design like Absorb is that the absorption is not inflammatory process, because it uses the lactate shuttle, which is part of the Krebs cycle. So there is hardly any inflammation with resorption of PLLA. And then the vascular integrity is restored by deposits of extracellular matrix, and then eventually by cells in those absorbed segments of the BVS. And this is what it should look like. This is the ideal golden tube. You basically have metallic DS on the left side, and there's neointimal proliferation versus an Absorb, and you hardly have any further narrowing left. However, when we went into the trial phase, the reason this technology is kind of not in the prime is because we are working on next generation, and the biggest reason was stent thrombosis. Stent thrombosis rates were about 1.54% in the Absorb arm versus 0.7, so almost twice the number that we would accept, so to speak. However, on further analysis, we learned that most of the stent thrombosis were from small vessels. So if you put in an Absorb in a very small vessel, reference vessel diameter less than 2 to 5, your stent thrombosis rates were significantly higher. But if the vessel wall was more than 2.25, actually it was very comparable and not that much more compared to a Zions. So there are certain clear theoretical advantages, such as late lumen enlargement. As you can imagine, once the scaffold is absorbed completely, there is progressive positive remodeling of the vessel, which is without any associated late stent malapposition. And that can potentially lead to improvement of the vessel wall diameter, as you can see over the next 2 to 3 years after the BVS is completely absorbed. So I think this is a very, very interesting idea. for vascular healing. But also, when you put in a rigid metallic stent, you potentially can lose the pulsatility of that particular vascular segment. And human vascular smooth muscle cells grown into pulsatile conditions rather than static conditions show more cells organized in physiologic and functional manner. So why is that important? Because once you have arterial pulsatility and you got more organized vessel cells, you actually have increased nitric oxide production, which then upregulation of eNOS as well as eNOS mRNA is directly related to increase in cyclic strain. So that potentially may lead to improved vasomotion as well as better flow. Not only that, the neocap, the plaque seals usually at about 2 or 3 years. But then the stent thrombosis remains a big noise. So we kind of try to work around that, not only avoiding it in small vessels, but improving the technique. So, for example, post dilating the PVS absorb, making sure every case has done imaging, and then prolonged DAP, whether 12 months or maybe even 24 months. But the real challenge is going to be in continuing to improve this device if we believe PVS is the future of human coronary stents, whether we make them thinner struts, or we improve their mechanical properties. And to come across this challenge, there are varieties of BVS getting developed right now. I mean, there's a 2-page list I'm going to share with you today. Again, none of them are available commercially. Even in Europe right now, the programs are more in people's garages in a way. But there is a lot of excitement about magnesium-based BVS alloys. Because there are several challenges which remain, right? I mean, we talked about shrinkage on the scaffold, but you have to worry about if I post that at a very high pressure, will it break the links, poor deliverability, and obviously stent security retention. But then there are perception challenges. It's too big a device, it delivers poorly, the struts are very thick, the plastic stent won't have enough strength, and using complex disease is limited, and scaffold thrombosis, as we have mentioned earlier, at 1.5%. Okay, so then there are some other nuanced stent. Tryton has made the stent or stent delivery system for bifurcation stenting. Unfortunately, it's still made out of bare metal stent. I think a drug-eluting stent of this would be very, very promising. But basically, you have 3 zones: a side branch zone, a transition zone, and a main branch zone, which is much larger in diameter, but it has gaps, so to speak, where you can actually deliver the side branch stent through it. But the real advance, to be honest, is probably around ultra thin. I mean, we have gone from 140 microns now down to 80s, and now we are going below 70 microns. I think that compared to thicker struts continues to outperform them. I mean, we have many trials, more than 10 RCTs with more than 11,000 patients on ultra thin struts. The one which is available in the US right now is Orsiro, which is only 16 micron thickness. And the TLF rates, as you can see, are definitely comparable, and also lesser than second generation drug-eluting stents. So this is very encouraging news. So what we have is this challenge for us. We have this challenge where there is increased event rates at around 1.8% per year after the first 2 or 3 years, and it continues to persist. And that's why more than often in trials which compares PCI versus CABG, we almost always lose out at 2 years onwards. So in the ideal world, if you can flatten this curve to this green line where you hardly have any perceptible event rates after the first year or 2, I think that is where the healing concept of drug-eluting stent should come on. Because yes, in 1977 we went to focus on getting the artery open. Bare metal stents was keeping the artery open. Restenosis was reduced by drug-eluting stent, but the future DAS is all about optimizing healing. With this presentation, with this slide, I conclude my presentation today. I hope you all have enjoyed it. This is a little deep dive into coronary stent design. If any of you guys have a biomedical engineering mindset, I hope this helps you. Maybe you can develop your own stents. And wish you good luck, guys. Please join us next month again for CV Live Ischemic Heart on Monday evening. Thank you and have a good evening. Bye bye.